Good afternoon, dear colleagues, dear patients. Today I want to talk about some practical aspects of the beta-blocker therapy in patients with heart defects, Down syndrome, Turner syndrome, and SGR syndrome. Most of all, with respect to improving the catch-up growth in these children. Looking back to the beginning of the beta-blocker therapy of pediatric heart failure in children with congenital heart defects, I introduced it in 1995 with the first beta-blocker therapy, early postoperative in a girl after Fontan operation with diffusion. 1 year later, I treated first infants with severe heart failure, most of all with single ventricle with a beta blocker published in 1998. We start the first prospective randomized trial in infants with severe heart failure due to CHD published in 2000. I treat the first baby with heart failure due to multiple liver hemangioma with propanol in 2003. 5 years later, the French group published their results, and now it is a very popular therapy. The first prospective randomized trial, beta blocker trial, after surgery of congenital heart defect, was published in 2007. Looking to the publication to the therapy in PubMed, there is the first positive results of beta blocker therapy published by Finn Wagstein in 1975. There's a long discussion up to the recommendation in the first guideline in 2000. I published the first cases in pediatric heart failure in 1998, and unfortunately, there are only a few publications in pediatrics indicating with the red color in this sheet, and most of all, there are no practical trials. Most of all, there are real views from colleagues who have no own experience with beta blocker therapy. Today, we have to realize that beta blocker therapy of severe heart failure in infants is much more than a life-threatening therapy. It has long-term consequences based on the epigenetic models that suggest a complex early childhood imprinting process in the first 1,000 days of life, called the developmental origin of health and disease. In this concept, early life stress by intrauterine growth delays, stunting, heart failure, prematurity, inflammation, social deprivation, and neglect have long-time consequences for health in humans. There are developmental disorders like growth failure, attention deficit hyperactivity disorder, and perhaps obesity. The long-term consequences are hypertension and the metabolic syndrome that have a big impact on life expectancy. This is the base of our early life stress model. We measured early life stress first with norepinephrine levels, later with heart rate variability, and we expect an impact on neurodevelopment like attention deficit disorder, cytokinesis failure with myocardial dysfunction, autonomic imprinting of heart rate with a variability that have an impact on the cardiovascular risk, endothelial dysfunction that have an impact on hypertension and short stature. In our first publication to this topic, 2016 in PLOS ONE, We analyzed the data of 100 children with growth failure and realized that the patients with heart defects and syndromes have the lowest vagus activity in this group. There is a low impact on vagus activity in patients with constitutional growth delay, small gestational age, and growth hormone deficiency who have the same height. Moreover, we realized that most of these patients develop attention deficit disorder uh, with and without the treatment with methylphenidate, and this may be related to this low vagus activities. However, the most important data are the measurement of early life stress in this group with starvation, heart defects, or prematurity. And indeed, early life stress is measurable by norepinephrine levels. We measure the data in infants with heart defects or heart rate variability indicated by the parameter RMSSD. The data in premature infants show normal stress in preterm without complications, but elevated norepinephrine levels and decreased heart rate variabilities in those with neurologic disorders or cerebral palsy. In the same range, we measured very high norepinephrine levels in infants with univentricular hearts and in infants with Down syndrome and congenital heart disease. And in this group, we measured the lowest vagus activities at all. After the publication of our prospective randomized trial using propranolol in infants with severe heart failure in 2000, the pediatric cardiologists have to decide if they further use ACE inhibitors and diuretics to treat heart failure in this group, or if they de-escalate neurohormonal activation in early lifestyle with beta-blockers as shown in our study. Unfortunately, in Germany and many other countries, the pediatric cardiologists decide against beta-blocker therapy and use further ACE inhibitors and diuretics. And unfortunately, we observe an increase in mortality of patients with congenital heart disease in Germany starting in 2010. This was the reason why I stopped my university career in 2004 and continue my project in a little hospital in Bad Mergentheim from 2005 to 2020. The only available data are from this patient treated in Bad Mergentheim, and most of all, these patients have atrioventricular septal defects or univentricular hearts, and around 50% of the patients have chromosome anomalies like Down syndrome. These are the most problematic infants in infants with congenital heart defects. Today we have to realize that infancy is the most important time to improve autonomic imprinting in infants with early life stress, for example, due to congenital heart disease. If the disease has developed in later life, there is no plasticity, and we only can treat the problems like hypertension or cardiovascular risk. Looking to the three groups treated with beta blockers in prospective trials, we have a high impact of beta blocker therapy on heart rate variability in infants with severe heart failure treated with propranolol. We have an around 80% increase of vagus activity indicated by the parameter RMSSD in this patient group. If the infants have no heart failure and they are treated with propranolol due to hemangioma, there's only little effect on heart rate variability. And in later life, in adults with congenital heart disease, bisoprolol have nearly no impact on heart rate variability in those patients who developed heart failure. There's a long time I have to wait on comparable data about somatic development and children with congenital heart defect. And in 2025, the German data are published from the Leipzig group. And we can realize on this paper that only patients with mild or moderate heart defects have a catch-up growth and a catch-up growth in head circumferences. Those with severe heart failure have no catch-up growth in head circumferences, and this has a high impact on neurodevelopment. What about my children treated with propranolol in early infancy? And we see they have the lowest the most important microcephaly, and they uh, uh, have a catch-up growth to normal values in 4 years of life. Looking to the high data, this is the same problem. There's only a catch-up growth in those with mild and moderate heart defects, and there's no catch-up growth in patients with severe heart defects. Looking to my data, we have very low heights at the beginning of the therapy due to the severity of the heart defect, and there's a very good catch-up growth in my patient group. I do not divide it in females and males uh, because the groups are only 17 patients. And to complete it, that is the same values in the body weight that is very low at the beginning, and there's catch up of body weights in my patient groups. What about the children with Down syndrome? They have special percentiles published by Simel. Simel measured Down patients with and without heart defects, and we see in this slide that patients with heart defect have lower heights compared to patients without heart defect. Treated with propranolol, there's a very good catch-up growth in my 8 patients with Down syndrome and congenital heart disease, and I compare it with some patients treated for other cardiologists without propranolol, and they have a very bad catch-up growth. We have to realize that the growth in patients with Down syndrome directly correlate with neurodevelopment. Looking to the literature, there are only data from South Africa and Brazil uh, of the growth of patients with Down syndrome and heart defects treated with standard therapy and operation, and there's a bad catch-up growth in these patient groups. And compared to healthy Down patients, we have very good data in our 8 patients treated with propranolol. I have the luck to treat monozygotic twins with discordant heart defects. One child have a fallow and the other is healthy, and we can compare the growth of these two infants, one with a heart defect treated with propranolol and the other is healthy. There's a complete catch-up growth of the uh, twin with the heart defect with 5 years of age. This stands for height and hence head circumferences with a severe microcephaly of the twin with the phallotetralogy. These twins have uh, are genomic identical and have a complete other phenotype. I compare the Holter ECGs of these twins uh, over 10 years. And these are the data of the twin with the heart defect with very low valgus activity indicated with the high frequency power in the Holter ECG. This improves with age, and we can compare it with a healthy twin with the same genetics. And indeed, there is a higher heart rate variability at birth and higher heart rates, but after introducing propranolol in the first week of life, the twin with phallotetralogy developed normal heart rate with a variability despite shunt operation, despite severe heart failure, and we can stop the beta blocker therapy after corrective surgery with 6 months of age. After that, the heart rates and heart rate variabilities are completely identical between these twins. And we see that the beta blocker therapy up to corrective surgery decrease the heart rate significantly uh, in comparison to the healthy twin. This catch-up growth seems to be very important for quality of life in later life. In this publication from 2025, we can show that the high trajectories are associated with the exercise capacity in children with congenital heart defects. The better the catch-up growth, the better the physical performance in later life. Based on our model of autonomic imprinting, we have to expect an impact on later cardiovascular risk. Looking to vagus activity in the human life cycle, we have an increase of vagus activity within the first 1,000 days and during puberty. In puberty, the humans have the highest vagus activity that decrease up to their death. There are some patients with low vagus activity at birth, indicated at red, normal vagus activities in gray, and those with high vagus activity indicated as green. And all this have an impact on life expectancy. There are some patients with low vagus activities at birth, for example, premature infants, for example, those with congenital heart disease, for example, those with growth failure, and for example, those with attention deficit disorder. And all this has an impact on cardiovascular prognosis. By knowing this, we can understand the risk factors for cardiovascular fatal and non-fatal events in children. There's only a low impact due to hypertension, body mass index, triglycerides, and nearly no impact of cholesterol. but there is a high impact of smoking, attention deficit disorders, or growth hormone therapy compared to a low impact of low birth weight on long-term cardiovascular prognosis. Most of these data are from Sweden, or with the very good data of the registries, and there is the hazard ratio of for coronary heart disease, myocardial infarction, stroke, heart failure, cardiovascular death, and all-cause death. And again, there are relatively low values for hypertension, low birth weight, and higher values for attention deficit disorder and growth hormone therapy. We tried to improve cardiovascular prognosis in patients with growth failure and used omega-3 fatty acid in 35 patients with an age of 6.6. And indeed, we realized an improvement of height SDS in this patient group, but no improvement of blood pressure or body mass index. However, in this publication, we found a significant impact of omega-3 fatty acid supplementation on low vagus activities and high heart rates. In this publication, we compare the impact of omega-3 fatty acid supplementation in 4 patients group: those with premature ventricular contractions, those with obesity, those with attention deficit disorder, and those with third stage, and there are the same significant effects of omega-3 fatty acid supplementation on heart rate and heart rate variability. We had demonstrated that children with syndrome have the lowest vagus activities, and our interest is to improve the vagus activity in this patient group, like children with or girls with Turner syndrome. There are the data in Turner patients treated with growth hormone, early, late, high dose, low dose, and all these patients have a better growth up to childhood. Looking to the natural history, there is a loss of height within the first 4 years of life. I know if this patient was treated with growth hormone, and there's a later decrease due to the missing sexual hormones. This is the case with the Turner syndrome, born with a weight of 1 kilogram and a height of 35 centimeter due to small gestational age. This is the most problematic patient with respect to height and cardiovascular prognosis. Due to arterial hypertension, we early use propranolol to treat hypertension and later carvedilol. And there's a dramatic catch-up growth within the first 5 years of life, up to the 99 percentile for children with Turner syndrome. Later, we used growth hormone for further improvement of growth up to puberty, and after puberty treatment, we will reach normal height. Other 2 girls are treated with omega-3 fatty acid due to short stature and Turner syndrome, and they grow over the 90 percentile before starting growth hormone. One of these girls changed to university and was treated with growth hormone, and omega-3 fatty acids are stopped. We see no improvement of growth, but unfortunately, the girl developed a severe obesity, looking to the BMI percentile after starting growth hormone therapy. And due to obesity, she developed hypertension, no treated with carvedilol. In this slide, I demonstrate my publication citations within the 36 years of altruistic research. I have no support of my research, but I publish all my data, most of all open access. I was successful with my publication at university, but the success improved with the data published from the little hospital, the Caritas Hospital in Bad Mergentheim, and I further published my data from private practice with, and I'm happy about the increasing citation number. Thank you for your attention.